Hello, everyone. And on behalf of the ASG, I'm Muriel Finkel, and I welcome you all to our ATTR Amyloidosis webinar. You can view all previous webinars on our YouTube channel and on our website, and this one will be up there soon. If you're on our mailing list or have joined our Facebook group, then you'll be notified when it does get on there. We've resumed a few in-person events, and our upcoming face-to-face meetings are posted on our website as well. Of course, the big Chicago meeting, that's the one we're all waiting for, right? That's the last weekend in October. I'm excited to say that all of today's presenters will be joining us in October. We have about 20 other amyloidologists that'll be coming. If your center is ever interested in hosting a local meeting, please let us know. Send me an email at muriel@amyloidosissupport.org. We would love to have a local face-to-face in-person meeting at your center. For today's webinar, you'll not be able to post comments in the chat. We do appreciate you mailing in your questions. We have a lot of questions, and we're going to try to get to as many as we can. If we don't get to all of them, our doctors have promised to write us an answer and put it, and then I'll send it via email back to the people that have sent them in. If we run out of time, then we'll definitely get to as many. We'll get to as many as we can. Okay, Paula will be posting links and other valuable information in our chat section, and Paula will explain later how you can save that chat and refer to it later. Speaking of Paula, in the control room today, we have Amyloidosis Support Groups Executive Director, Paula Schmitt. Paula,
hey, everybody.
And our Special Projects Director, Bob Gibson.
Hello, everybody.
Okay. Our presenters today are cardiologist, Dr. Richard Cheng from the University of Washington.
Hi, everyone.
Dr. Melissa Lyle from the Mayo Clinic in Jacksonville.
Hi.
And neurologist Dr. Chafic Karam from the University of Pennsylvania.
Hello, everybody.
Okay. We'll also hear from Intellia's Joy Olbertz, Alnylam's Harrison Weisz, AstraZeneca's Kristina Kipp, and our old friend Spencer Guthrie from Attralus. There will be a quick survey when this meeting is over, and we do ask that all of you fill it out, please. It's so important that you do. That way we know what you liked, what you didn't like, what you'd like to see next time. It really helps us in developing our future webinars. We'll be referencing treatments today, and we have a treatment chart, and Bob will put it up there on the screen so you can see it. But Paula will also be posting a link to it in the chat. You can print your screen, you can take a picture of it, or if you want another copy, you can email me at muriel@amyloidosissupport.org. We just don't want you wondering how to spell all the treatments that are going to be referred to today. So know that it's available right there, okay? And right now, we're going to be ready to hear our first presenter, Dr. Melissa Lyle from the Mayo Clinic in Jacksonville. So, Dr. Lyle, take it away.
Perfect. Thank you so much, Muriel. Let me share my screen. All right. So I will be talking about current and emerging therapies for TTR amyloid. So as we all know, there's been a lot of advancements in the field of transthyretin cardiac amyloid. And not only has there been increasing awareness and recognition, but also the development of effective therapies. So during my talk today, I'm going to briefly review the pathophysiology of TTR amyloid, and also we'll talk about current TTR targeted therapies, and then discuss some emerging therapies. But before I get started, I just wanted to review some patients that I recently saw in amyloid clinic to highlight how different patients' presentations can be. So I recently saw a 78-year-old man who had an aortic valve replacement and had presented with shortness of breath and fluid accumulation in his belly. a 40-year-old African-American man who had peripheral neuropathy, and then also a family history of heart failure. And a 68-year-old female who presented with very advanced heart failure and actually undergoing an evaluation for transplant. So what do all three of these patients have in common? Well, they all have transthyretin cardiac amyloid, hereditary or wild type. And I think that this really highlights the different presentations and the different patients that we see with this disease. So what is amyloid? I like to think of amyloid as really an umbrella term. So this refers to a disorder of misfolded proteins. The misfolded precursor protein aggregates into what we call a beta pleated sheet configuration, and that forms amyloid fibrils. And these amyloid fibrils then deposit into different organs and tissues. There's over 30 different proteins in the body that are capable of aggregating into amyloid, and these are referred to as amyloidogenic. And the identification of that precursor protein really is crucial because that's what guides our therapy. So the two most common types of amyloid that affect the heart are AL and ATTR. And of course, we'll be focusing on TTR today. The A stands for amyloid, and the rest represents the precursor protein. So I like to really think about the precursor protein and then the protein factory. So what organ makes the specific protein that's causing a problem? And in TTR, transthyretin amyloid, the protein is the carrier protein transthyretin. It's previously known as prealbumin, and it's a carrier protein for thyroxine or thyroid hormone and holoretinol binding protein, so carries retinol or vitamin A. And the protein factory is mostly the liver. So again, we'll be focusing on TTR amyloid. And in TTR amyloid, the liver produces that precursor protein, transthyretin. And this is a four-sided protein or a tetramer. And that transthyretin protein, when it becomes unstable, or if it becomes unstable, it separates into smaller subunits called monomers. And those smaller subunits or monomers then aggregate together to form the amyloid fibrils. That's actually the rate limiting step of TTR amyloid, which is the dissociation of the four-sided protein into smaller subunits called the monomers. And ATTR amyloid is classified by either the presence or the absence of an inherited mutation. So if the mutation is present, then it's referred to as hereditary TTR amyloid, or if absent, wild type TTR amyloid, which is a process that occurs with aging. So transthyretin cardiac amyloid results in a very thick and stiff heart, and this can lead to progressive heart failure. So you can see here those amyloid fibrils weaving themselves into the heart muscle, making the heart muscle thicker and stiffer than it should, and then resulting in what we refer to as restrictive cardiomyopathy and essentially heart failure. So with increasing awareness and detection, we're now seeing increased prevalence of TTR amyloid, but the exact prevalence still remains unknown. Some estimate even as high as 500,000 with wild type amyloid cardiomyopathy. But again, the exact prevalence is unknown. There have been autopsy studies that have shown that wild type TTR deposits are noted increasingly with age, 20 to 25% of octogenarians and up to about 40% of patients over the age of 95. There have been some recent studies that show that patients hospitalized with heart failure with preserved ejection fraction, about 13% of those patients have concomitant wild type TTR amyloid. About 16% of patients with severe aortic stenosis who are referred for a transcatheter aortic valve replacement or TAVR also have wild type TTR amyloid. And 10 patients who undergo carpal tunnel release surgery also have TTR amyloid. And bilateral carpal tunnel syndrome is thought to precede heart failure by about 10 years. So what are the signs and symptoms of heart failure? Fatigue, shortness of breath, swelling in your legs and abdomen, unable to lie down due to shortness of breath. We call that orthopnea. And then also waking up gasping for air, as well as a cough at night, all can represent extra fluid buildup. Amyloid can also affect the electrical system of your heart, with heart rhythm problems resulting in bradycardia, or your heart rate being too slow, tachycardia, or your heart rate being too fast, an abnormal heart rhythm called atrial fibrillation, which is an irregular rhythm coming from the top chambers of your heart that we sometimes will need to treat with medications, cardioversions that also require a transesophageal echo or a visualization of the heart to check for clots prior, and then also in general, a risk of stroke needing blood thinners. And then occasionally some patients will have abnormal heart rhythms coming from the bottom chamber of their heart that require defibrillators. So this slide was shared with me by my colleague, Dr. Jose Nativi, from one of his more recent review articles. And this really highlights the multi-organ involvement, though, of TTR amyloid, of amyloid in general, but again, focusing on TTR amyloid. And specifically with TTR amyloid, we see a lot of musculoskeletal and orthopedic complaints. So carpal tunnel syndrome, back pain, lumbar stenosis, biceps tendon rupture, and then different arthropathies requiring shoulder, knee, hip surgery, and then also trigger finger or Dupuytren's contracture. So that's a very brief overview of TTR and how it really affects the heart, and then also the pathophysiology. But now I'm going to focus the rest of the talk on how do we treat TTR amyloid? What are the current therapies, and then what are the potential emerging options in the future? So first, I want to highlight a really fantastic review article, actually by Dr. Cheng and colleagues, so you'll hear from him in a little bit, but really it's a great overview of all of the different options that we have now for patients with TTR amyloid. So here are the main therapeutic strategies for treating TTR amyloid, and I'm going to focus a lot of time on stabilization and silencing. So stabilization refers to stabilizing that transthyretin protein. And so the four-sided protein, as I mentioned earlier, the rate limiting step is the disassociation of the four-sided protein into smaller subunits that then become misshapen or misfolded. And then silencing is silencing the production of TTR and stopping the production at the level of the liver. We'll also briefly discuss degradation and extraction. So this is a nice schematic that really highlights, again, the process. So just as a reminder, the liver being that protein factory, and actually the mRNA serves as the messenger to get the message to the liver to make this TTR protein. That TTR protein, four-sided, when it becomes unstable, breaks apart into four smaller proteins. Those smaller proteins are the ones that are then going to become misshapen, misfolded, aggregate together to form the insoluble amyloid fibril. So let's first start with TTR stabilization, and it really addressing that rate limiting step, because if there is no dissociation of the monomer into the dissociation of the tetramer into the four smaller monomers, then the amyloid fibril can't form. So stabilizers are oral medications that do not completely stop or reverse the disease, but they do slow progression of the disease. I'll be focusing on diflunisal, tafamidis, and acoramidis, or AG10. Diflunisal is a non-steroidal anti-inflammatory agent, or an NSAID, similar to ibuprofen, with TTR stabilizing properties. So it prevents the breakdown of that four-sided protein by essentially binding to the T4 binding site, or where the thyroid hormone would bind. And it's been shown to slow the rate of progression of neuropathy in patients with TTR amyloid, and also slow the progression of TTR cardiac amyloid. It's important to mention, though, that this is an NSAID, again, like ibuprofen, so lots of side effects, risk of bleeding in the GI tract, injury to the kidneys, and potentially causing fluid retention. There have been some single center retrospective studies that have evaluated diflunisal, and this is one from Boston University. And here you can see a survival curve. So on the vertical axis, that's the survival. And as you look at the curve with time, there is overall decline in survival. But diflunisal did slow the progression of disease. It's important, though, to emphasize that this was for early cardiomyopathy and also that these have all been retrospective studies with no larger clinical data. People with more advanced cardiomyopathy cannot tolerate diflunisal because it can cause worsening fluid retention and heart failure symptoms, and also can cause worsening kidney function. What about tafamidis? So tafamidis is an oral once-a-day medication that also stabilizes that TTR tetramer protein by binding to the T4 binding site, similar to diflunisal, without the side effects. Tafamidis was studied in the ATTR ACT trial. Patients were randomized to 20 milligrams, 80 milligrams, or placebo. And here's another survival curve. So this trial showed a reduction of about 13% in all-cause mortality with the pooled amyloid cohort, so patients on 20 or 80 milligrams. And again, you can see from this survival curve how tafamidis slowed the rate of progression of the disease. Tafamidis was also associated with about a 32% reduction in hospitalizations. It's again important to note, though, that the benefits were seen in patients with minimal symptoms, emphasizing efficacy in earlier disease states. We also think about something called a number needed to treat, so needing to treat about 4 patients before you could prevent 1 hospitalization. Later analysis did show that improvement in survival was greater with the 80 milligram dose, so that's what's currently recommended. Tafamidis was FDA approved in May of 2019 for cardiac amyloid, both hereditary and wild type, and it's available as Vyndaqel with 20 milligram capsules for a total 80 milligram dose, or as Vyndamax 61 milligrams. This was created for patient convenience and is bioequivalent to Vyndaqel. Tafamidis was also shown to reduce the decline in a 6-minute walk. So we utilize 6-minute walk to look at functional capacity. So over time, that functional capacity declines, but tafamidis again slowed the rate of decline, slowing progression of the disease. And it did the same with the Kansas City Cardiomyopathy Questionnaire, and that is an assessment of essentially quality of life. So quality of life did decline, but tafamidis dramatically slowed that progression. Because of these findings, the new 2022 heart failure guidelines actually gives tafamidis a class 1 recommendation for patients with wild type and hereditary transthyretin cardiac amyloid. And it does acknowledge, however, the cost. So I know there'll be lots of questions about that, but the potential financial toxicity associated. Acoramidis, or AG10, is another stabilizer which mimics the protective benefits of a TTR mutation, and that's how it stabilizes that protein. The Attribute study randomized patients to placebo or 800 milligrams of acoramidis twice daily, and the 12-month results, though, unfortunately did not reach the primary endpoint, and that was the assessment in that 6-minute walk test, the measure again of functional capacity. But we did see improvement in quality of life and reduction in heart failure biomarkers, so encouraging. Although we know that acoramidis stables the TTR tetramer, awaiting the 30-month clinical trial results. And just briefly, tolcapone is a Parkinson's drug like diflunisal and tafamidis that stabilizes the TTR protein by binding to a protein-specific binding site. It is different in that it crosses the blood-brain barrier, thought to stabilize TTR produced by other places other than the liver. So let's take a step back and look at the level of the liver. So can we stop production of transthyretin? So historically, this was done just for hereditary patients by transplanting the liver, but that's now, again, considered a historical treatment now that we have gene silencers. So silencer medications essentially travel to the hepatocyte or to the liver cells and stop production of TTR, dramatically reducing the amount that the body produces. And so if we remember that the liver, again, is the main protein factory, then these medications are stopping the messenger from getting to the factory so the product is not ever produced. So we have first generation and second generation silencers. The first generation silencers are inotersen and patisiran, and these have been FDA approved for hereditary TTR polyneuropathy. And so they work by different mechanisms, but are aimed at shutting down the production at the level of the liver. Inotersen is an antisense oligonucleotide. It's a 300 milligram subcutaneous injection weekly, and patisiran is a small interfering RNA agent that's given by an infusion every 3 weeks with pre-medication. Inotersen, the initial trial that had shown benefit, was the NEURO-TTR trial that showed stabilization of neuropathy. Side effects included some kidney effects and also low platelet counts. So important emphasis of close monitoring. And then also, because the function of TTR is to transport, one of the functions is to transport retinol, a form of vitamin A. Vitamin A supplementation is required, and this dose is just the daily recommended dose. We don't follow levels or adjust. So going back to patisiran, just very briefly, so the Apollo study was what led to the FDA approval. And in this study, the drug was showed to drop TTR levels, and studies have shown anywhere from 83 to 85% suppression. And you see this graph here is looking at something called the Modified Neuropathic Impairment Score, or the NIS score, which was developed by Dr. Dick at Mayo, Rochester. And I know we'll hear a lot more about the neuropathy side of things in later talks. But as you can see, the placebo shows a dramatic worsening of neuropathy over 18 months, whereas with patisiran, there was not only stop of the progression of disease, but some small neurologic improvement, largely with sensory function. So second generation silencers, eplontersen, which is still being evaluated in clinical trials, it's a second generation antisense oligonucleotide, so second generation version of inotersen. It's 45 milligrams subcutaneous monthly. And then vutrisiran, or Amvuttra, is a small interfering RNA, so a second generation version of patisiran, 25 milligrams subcutaneous every 3 months. The Helios A study was evaluating vutrisiran in patients with hereditary TTR polyneuropathy and demonstrated sustained reduction in the TTR levels and also improved symptoms of neuropathy. The FDA approved vutrisiran for hereditary polyneuropathy in July of 2022, also really as a more convenient option every 3 months. So what about the silencer clinical trials for cardiac amyloid? So we have FDA approval for neuropathy, but what about all of our patients with cardiomyopathy and just cardiomyopathy? So lots of ongoing exciting trials. So Apollo B is currently evaluating the role of patisiran in patients with hereditary or wild-type TTR cardiomyopathy. At 12 months, patisiran was associated with improvement in functional capacity, that improvement in the 6-minute walk test, and also in quality of life. So we're just awaiting longer-term evaluation. Helios B is currently evaluating vutrisiran, the second generation version of patisiran, in patients with cardiomyopathy, and the results hopefully are expected in early 2024. Cardio-Transform is looking at the Axia TTR LRX, or eplontersen, again for cardiomyopathy, with the primary endpoint being composite of cardiovascular mortality and recurrent hospitalizations. So again, just as an overview for current therapies for ATTR amyloid cardiomyopathy, oral stabilizer options, diflunisal off-label, no formal clinical trials, but some retrospective studies that have shown improvement, and particularly patients with early cardiomyopathy who may tolerate the drug. Tafamidis, acoramidis, or AG10 still in clinical trials. Gene silencers, so ongoing studies looking at patisiran, vutrisiran, and eplontersen for cardiomyopathy. So existing therapies don't address amyloid deposition, though that's already present in organs. So what about degradation and extraction? So doxycycline was previously found to disrupt TTR fibrils in mice, and TUDCA was found to be effective at lowering TTR levels as well, and thought to act synergistically with the doxycycline. But really, there have been only small studies, and they've shown no significant benefit for these drugs. So what about antibody disruption? Lots of questions and excitement around this. So PRX004 is a monoclonal antibody aimed at clearing existing deposits from the heart. Initial studies have shown for it to be safe in ongoing clinical trials. N1006 is also a TTR antibody that was developed to remove TTR, and in the phase 1 trial that was recently published, the antibody was found to be safe with no apparent drug-related serious adverse events. So lots of excitement around antibody disruption of amyloid deposits in TTR amyloid, and we eagerly await the results of further clinical trials. CRISPR-Cas9 therapy is a gene editing approach in which target DNA is modified or repaired, so preventing TTR from ever really appearing in the liver and being produced. This was the New England Journal of Medicine article in which 6 patients with hereditary TTR amyloid polyneuropathy had 97% TTR knockdown at about 1 year. And so these have been the initial proof of concept studies, and future clinical trials are coming up in the future, and so lots of excitement for this therapy as well. And just briefly, there's been a lot of news and buzz about this recent correspondence from the National Amyloidosis Center. There are a lot of questions that came in, and so this was a really interesting correspondence that described 3 patients with TTR cardiomyopathy, and they were found to have IgG antibodies to human TTR amyloid, and they essentially had an anti-amyloid immune response. So very exciting. This was just an observational study, though, so no future clinical trials would definitely be needed before we could comment further. So very briefly, though, what about advanced heart failure therapies? I've talked a lot about therapies and mentioned that the stabilizers in particular are better for earlier disease. So what about patients who are diagnosed late and present with advanced heart failure therapies? You'll be learning a lot more about this from Dr. Cheng in the later talk, but just to mention one word about cardiac transplant. So transplantation for cardiac amyloid was previously considered almost contraindicated in the past, but this was due to outcomes that were worse in the 1980s and 1990s, mostly related to actually AL amyloid. So concern for higher risk of recurrent amyloid deposition in the transplanted heart. But now we see for more current data that outcomes post-transplant for patients with amyloid are actually similar to patients who are transplanted for non-amyloid indications. So there also does not seem to be a lot of difference in post-transplant survival between AL or TTR. So definitely, if no contraindication, something that would be considered for someone with advanced heart failure symptoms. And I highlight this just as I kind of start to finish up that really taking care of the TTR amyloid patient involves a lot of different subspecialties. So as a cardiologist, I frequently work with my neurology colleagues, my orthopedic colleagues, and of course our geneticists as well. So it's always a team effort to make sure that we're providing the best possible multidisciplinary care. I did try to touch on just a few commonly asked questions, and obviously we'll have the Q&A session, but there were a lot of great questions that came before the webinar today. And so one question is stabilizers versus silencers versus both. And I don't think we have a clear-cut answer to this yet. Hopefully we will have ongoing information from clinical trials given HELIOS-B and CardioTransform allowed patients who were being tested with gene silencers to also remain on tafamidis. So I think we will learn a lot more about the role of concomitant therapy, but I just don't think we have the answers currently. There were some questions about natural remedies, thinking about green tea. So EGCG is found in green tea, shown to inhibit amyloid fibril formation in hereditary TTR non-human studies. So smaller anecdotal studies, no clinical trials, not a lot of evidence, but did show that consuming 500 to 7 milligrams daily led to no progression of the disease. But this again is much smaller studies, no major clinical trials. And curcumin is thought to have maybe some potential neuroprotective effects as a stabilizer, but again, therapeutic doses have really been intolerable. And then also, as we get people on this therapy, how often do we repeat their imaging studies, their echoes, MRIs, and their nuclear PYP scans? So I think that when new clinical symptoms arise, if a patient presents with worsening symptoms, then it is always very reasonable to repeat echo, MRI, or nuclear scans, but currently no role for serial scanning just for monitoring of disease progression. And so I'll end with this slide that I adapted from a slide from my friend, Dr. Julie Rosenthal. Where have we been and where are we going? This is obviously a very exciting time for TTR amyloid. If we start to think back to the 1800s when amyloid was first described, then to the 1949 when amyloid was found at autopsy, to 1990 when the first liver transplant for hereditary polyneuropathy was performed in Sweden, to then really the huge advancement with Dr. Kelly at Scripps Clinic in 2003, finding stabilization of the TTR tetramer. And then fast forwarding to FDA approval of the first generation silencers in 2018, so patisiran, inotersen, tafamidis's FDA approval in 2019, to now FDA approval of vutrisiran, and then the future looking towards monoclonal antibody studies as well as CRISPR-Cas9 therapy. And so with that, I will end.
Thank you so much, Dr. Lyle. I found that the only thing I wasn't around for was the 1854 thing. So I guess that okay, there's something I wasn't around for. That's good. Okay, next, we'll get back to you with questions later, of course. But next we're going to hear from Dr. Cheng. So Dr. Cheng, take it away.
Great. Thank you so much for the invitation to give this talk. So I just wanted to say, that was a very exciting overview by Dr. Lyle regarding these emerging targeted therapies. I think this field is definitely moving forward really fast. So I have the privilege of giving a talk on how to manage heart failure symptoms and other cardiac manifestations, which may not be as exciting as all these emerging therapies, but I think it's just as important in terms of ensuring optimal outcomes for our patients. So over the next 20 minutes or so, I want to cover really two key aspects, and these are really the take-home messages from this talk. So I want to go over the common cardiac manifestations of what we need to look for when TTR infiltrates the heart. And I'm going to talk about how we manage TTR-associated heart failure. Ultimately, for many patients, whether this is wild type or hereditary TTR, the cardiac limitation becomes the biggest problem long-term for many of our patients. So Dr. Lyle touched on this nicely earlier. Essentially, what ends up happening with cardiac amyloid is when you form these amyloid fibrils, this will infiltrate into the heart. So on the top here, we have normal myocardium. So normally you have these heart cells, and then you have this extracellular space. And what happens is these cells contract and relax normally. What ends up happening is when you start to develop amyloid, it deposits into this extracellular space between the heart cells. And when this happens, it makes the heart very thick and very stiff. Over time, because this heart is getting so thick and stiff, it can't relax normally. And when it can't relax, what ends up happening is the pressure starts to build up, the fluid starts to back up, and patients will end up developing heart failure because they start to retain fluid. In addition to that, because of this deposition of the amyloid in this extracellular space, scar formation happens in every chamber of the heart, and this can lead to arrhythmias, both arrhythmias that go fast, but also arrhythmias that go slow, because this can infiltrate the conduction system and lead to conduction disease. You saw the slide earlier from Dr. Lyle already, but this touches on the common manifestations systemically with TTR amyloid. I'm going to focus mostly on the cardiac manifestations, being a cardiologist. So we're going to talk about heart failure, so the retention of fluid leading to shortness of breath. And then we're going to touch on atrial fibrillation, which is a fast arrhythmia, which is very common. And then I'm going to touch briefly on conduction disease. But I think it's important to keep in mind that there's a lot of other manifestations that can happen with TTR, such as all these musculoskeletal causes, as well as significant neuropathy. And Dr. Karam will touch on all of these neuropathies later. So from a treatment paradigm perspective, this highlights the various therapeutic options we have and really underscores how much we've advanced as a field. So Dr. Lyle already talked about these TTR specific treatments nicely, and I'm going to focus mostly on how we manage the cardiac involvement with more traditional heart failure therapies. So this is the framework that we propose to think about when we look at patients with heart involvement from TTR amyloid. So essentially, there's this preclinical and early clinical phase where patients can be asymptomatic, and then once you have progression of disease, the initial presentation will often be shortness of breath, otherwise known as dystonia exertion. Arrhythmias start to occur. During this early phase of treatment is really with diuretics because you want to get rid of the excess fluid, and in doing so, you can make patients feel better because you get rid of that excess fluid and you decongest the lungs. Over time, if this progresses, this will lead to more restrictive filling where the heart gets very stiff. It's very difficult to fill the heart. And what ends up happening is there will be recurrent bouts of heart failure. But as a field, we're trying to prevent patients from reaching the stage. We really want to maintain patients in this either preclinical or early clinical phase. So early diagnosis is really critical to start treatment so that patients will never progress to these more advanced stages. Once you reach these more advanced stages, if this progresses to advanced heart failure, then we're looking at therapies such as heart transplant. I think in order to understand why you develop symptoms, it's really critical to understand what's going on from the cardiac standpoint. So this is a pressure volume loop. We look at this a lot in cardiology, and it's a little bit complex, but in gray here, this is a normal heart. You can think of this as a heart contracting and relaxing. Normally it follows this line in this counterclockwise fashion. What ends up happening with amyloid, whether it's wild type or hereditary, this curve will be shifted. And what you're seeing here is this curve on the bottom represents the pressure volume relationship. So this is shifted upwards and to the left. So for any given volume, your pressures are going to be higher, and this is why fluid's going to back up into the lungs. But I think the other thing I want to draw attention to is the stroke volume is really measured by this line on the left and the line on the right. So in a normal heart, you have this nice wide stroke volume, but with TTR amyloid, this stroke volume is impaired. It's, as you can see, this line going from left to right is now narrower, and because of this, the stroke volume is lower, and this leads to fatigue. But in addition to leading to fatigue, you don't push as much blood to the rest of the body, so you can underperfuse other organs, such as the kidneys. So for this reason, this can lead to heart failure, and ultimately the therapies that we use, it's really trying to reverse some of these changes that occurs with TTR amyloid. So I'm going to start by talking a little bit about digoxin. Many of you are familiar with this. This is one of the oldest drugs. I would say it's somewhat controversial in terms of its use in amyloid. So even though historically we said it was contraindicated, I think more recent data suggests it can be used very cautiously in patients. So there's been 2 studies looking at this. On the left here, there's a study from the Mayo Clinic. This is predominantly light chain amyloid patients. But when they looked at digoxin use, it was mostly in patients with AFib or atrial flutter, essentially for rate control. So when you develop atrial fibrillation, it can go really fast. Digoxin can help slow that down. And when you use this cautiously, appears to be generally well tolerated and relatively safe. Another study from the Cleveland Clinic also looked at the use of digoxin, and this was a mixed cohort of TTR as well as light chain amyloid patients. Similarly, what they found is the majority of patients with digoxin were using it for rate control for arrhythmias, less commonly for heart failure. But I think the take-home point is really digoxin can be used in general for rate control. For example, if you have atrial fibrillation, you're going very fast, and if you don't tolerate beta blockers, you can consider digoxin to slow down the rate as long as you monitor patients closely. And based on these two studies, it appears to be relatively safe as long as you follow the levels very closely. What about beta blockers? I mentioned this already. We use this in heart failure, in traditional heart failure. What this does is it essentially relaxes the heart and gives it time to recover. I would say in amyloid patients, the data has been very mixed. So this is data from 11 Italian centers. It's cross-sectional, looking at the use of beta blockers. There's really no outcomes in this study, but what they found is the majority of patients on beta blockers were on them for rate control for atrial fibrillation. However, what's also important is doing follow-up. 43% of patients actually stopped beta blockers because of intolerance, because of worsening heart failure. And the mechanism behind this, if you remember, drawing back your attention back to a pressure volume loop we talked about earlier, because the stroke volume is very low. So with each beat, you're pushing out less blood, so you become very heart rate dependent. And because of this, if you slow down the heart rate too much with beta blockers, this can lead to worsening symptoms of heart failure. This is why we think some patients probably do not tolerate beta blockers, and why it's very important to be very cautious when you use beta blockers, even in treating heart failure. In other heart failure patients, you want to give it to everyone, but in amyloid patients, you have to be very careful. So we actually looked at this so I looked at this with Dr. Maurer at Columbia University. This is a paper we published a couple of years ago when we looked at patients with TTR amyloid, beta blockers compared to no beta blockers, and blue versus red. There's really no difference in outcomes. So while in other heart failure patients, there's a clear benefit, at least in this study, there appeared to be really no difference in outcomes. More importantly, if you look at patients that stopped beta blockers upon follow-up, some blue, it's patients who stopped, red, those that continued, patients who stopped beta blockers appear to do better. And this goes back to the question of whether beta blockers are impairing cardiac outputs because of the lower stroke volume. What about other heart failure therapies? We often use ACE inhibitors as well as ARBs. So these agents essentially decrease the negative neurohormones in patients with heart failure. And it's very effective in other heart failure patients, but in TTR amyloid, there appears to be no clear benefit. And lastly, we often use a drug class called MRAs, such as spironolactone. At least in this study, there appeared to be no difference in outcomes, whether patients were on MRAs or not on MRAs. However, more recent data from Brett Sperry, he did a retrospective analysis of TOPCAT. So TOPCAT was a randomized clinical trial looking at patients with heart failure with preserved ejection fraction, not specific to cardiac amyloid, but these patients were randomized to spironolactone, which is an MRA compared to placebo. What he did is he took a cohort enriched for TTR amyloid. So these were not confirmed to have amyloid, but these patients were more likely to have amyloid based on certain echo parameters. And he looked at whether patients benefited from spironolactone or not. And what they found is in this cohort enriched for cardiac amyloid, patients appeared to benefit from spironolactone. So essentially, in this study, there appears to be a significant benefit with spironolactone. So because of all this conflicting data, I think you need more studies looking at this. This was a very recent study published by the UK amyloid group led by Mariana Fontana and her colleagues. And so it's a very large cohort, as you know, in the UK, because of the way their healthcare system works. Patients are referred centrally to the National Amyloid Center, so they have a lot of patients. So they again looked at beta blockers, ACE inhibitors, ARBs, as well as MRAs. So again, the traditional heart failure therapies in these patients. Interestingly, what they found here is for beta blockers, for patients with an ejection fraction, so heart squeeze function, less than 40%, there was a significant benefit with beta blockers. Keeping in mind that in this study, these TTR patients tended to have earlier stage disease, underscoring the importance of early diagnosis. And for patients on beta blockers, they were in general on bisoprolol, which is a beta blocker that is used frequently in the UK, less commonly in the United States. and also in very low doses. So in patients with low ejection fraction, if you give them low doses of bisoprolol, they appear to benefit in this study. For ACE inhibitors and ARBs, consistent with the prior data, there appeared to be no difference in outcomes. And then for MRAs, spironolactone, they again showed a significant benefit if you use this in patients with TTR for all comers. So in summary, in this study, beta blockers appear to be beneficial at low doses for low ejection fraction, and MRAs appear to also be beneficial. So the question is, what do the current guidelines state? So I like this slide because it summarizes the various guidelines that currently exist from the European Society of Cardiology, German guidelines, Canadian guidelines, American guidelines, and Japanese guidelines. So in general, they all recommend the use of diuretics because this decongests the patient. So if you're retaining fluid, this will get rid of the excess fluid and immediately make you feel better by getting rid of this excess fluid. However, what about the other therapies? For beta blockers, the current guidelines recommend against the use of beta blockers. Keeping in mind this is before the most recent UK study because of concerns that this is going to decrease the stroke volume. It recommends against the use of ACE inhibitors and ARBs because there, as you saw, there's really, even with the recent data, there's no benefits. The concern with this is this can lead to low blood pressure and cause dizziness in patients. What about Entresto? So this is sacubitril valsartan. There's really no data for this in patients with TTR. And then lastly, with MRAs, at least with these guidelines, right now the data has been and recommendations are very mixed. This is before the more recent studies. I would argue that based on the more recent data, we probably should consider the use of MRAs. So how do we put this together? So essentially with TTR amyloid, if you remember, this leads to alteration of the pressure volume loop, where this is going to cause a decreased stroke volume and higher filling pressures, leading to congested lungs, as well as this low stroke volume. Because of this, you'll present with hypotension, chronotropic incompetence, because you can't augment your heart rate as much, fatigue, exercise intolerance, as well as shortness of breath. So for treating heart failure, current guidelines recommends against the use of beta blockers, against this use of ACE inhibitors, ARBs. You can consider MRAs, and you should give diuretics to everyone. What we would say is, based on all the recent data, I think we should reframe this. You really need to individualize the approach for use of beta blockers. I would not recommend beta blockers for patients with more advanced disease, but for patients with a low ejection fraction, you can consider this at low doses. But I think this also underscores the importance that you see a specialty center, because you really need to individualize the approach. You can't just give this to everyone, because some patients are not going to tolerate this, while others may benefit from it. ACE inhibitors, ARBs, you should probably avoid it. In all the studies, there's really no signal of benefit. MRAs, you should probably use this consistently based on the more recent data. And I think for diuretics, we should continue to use this. So these are the more conventional heart failure treatments. I'm going to move on now and talk a little bit about arrhythmias. So if you remember with the TTR amyloid, this is good deposit in the extracellular space. This is good deposit in all of the heart chambers as well as the conduction system. So this can essentially lead to any type of arrhythmia. Most commonly, in 50 to 70% of patients, you'll develop atrial fibrillation. So what ends up happening is the upper chamber of the heart, because of the irritation from the amyloid deposition, it's going to fire very fast. The major concern from this is this can lead to thrombus formation and can lead to stroke. And for this reason, we recommend all patients be on blood thinners or anticoagulation to prevent the risk of stroke if you have atrial fibrillation and amyloid, because the risk is very high, and conventional risk scores really do not capture this risk because they don't take into account the presence of amyloid. In addition to this, amyloid deposition can lead to heart block because of conduction disease. Amyloid can and will deposit everywhere and can impact this conduction system, leading to need for pacemakers. And lastly, it can lead to other arrhythmias. But I think in this group, we have less data. So going back to atrial arrhythmias, so atrial fibrillation, which is most common, this is data from the Mayo Clinic looking at 58 patients with cardiac amyloid, a mix of TTR and light chain amyloid. But what they found, and I think what's critically important to highlight, is in these patients with atrial arrhythmias referred for cardioversion, in a lot of these patients, when you look, it turns out that many patients will have intracardiac thrombus. This included patients in atrial fibrillation for a short period of time, as well as patients on chronic blood thinners. Because of this, we recommend that all patients with amyloid and AFib be on long-term blood thinners, because the risk of a clot is very high. But in addition to that, if you're being considered for cardioversion, you should get a transesophageal echo. That's where we look and make sure there's no clot before the cardioversion. We don't do this consistently in other patients that are on long-term blood thinners. But in patients with amyloid, we have to make sure that there's no clot present, even if you're on blood thinners, because of this risk. In this study, 13 of 58 had thrombus, despite many of these patients being on blood thinners. So this is a real risk and something to consider. So for management of atrial arrhythmias, there's high rates for atrial fibrillation, 50 to 70%. We should always use blood thinners if atrial fibrillation is present in amyloid. What about Watchman or closing the left atrial appendage? We don't really have data on this. We're not sure how effective this is. I touched base a little bit on the use of digoxin. If you have to use an antiarrhythmic, amiodarone tends to be pretty well tolerated. So I'm going to move on a bit and touch briefly on kidney involvement. I was asked specifically to talk about this. So for light chain amyloid, this usually deposits directly in the kidneys, leading to proteinuria. This is not necessarily the case with TTR. The reason why TTR patients get kidney dysfunction, it's usually because of the adverse effects from the heart involvement. So what ends up happening with TTR amyloid is the heart gets very stiff, it's unable to fill. Because of this leads to low cardiac outputs. It leads to high filling pressures and congestion of the kidneys. So the kidneys get very decongested. The kidneys get very congested. In addition to that, you don't push as much blood forward. So you don't get as much blood to the kidneys. In addition to that, you get the upregulation of negative hormones. All this results in indirect kidney dysfunction, but this is really driven by the cardiomyopathy. So if you can decongest the heart and treat the heart appropriately, theoretically the kidneys will also get better. For patients with hereditary TTR, in addition to direct effects on the heart, there will be nerve involvement and orthostasis and autonomic neuropathy. This can also contribute to kidney dysfunction. But ultimately, the treatment is really to treat the underlying cause, which is the cardiac involvement from TTR. What about valve involvement? I touched on that earlier. But aortic stenosis is very common. So the major valve exiting the heart can get calcified. Many patients with TTR will also have aortic stenosis. Both of these are diseases of aging, but essentially you can get calcification of this valve. It narrows and you can't get blood through. So it's very common. I think the way we treat this, we treat it like any other patient. The key take-home points specific for TTR amyloid is the first thing is because the heart is not functioning normally. Oftentimes, even though the aortic stenosis doesn't look that bad, it can be worse than it appears. You can have low flow, low gradient AS. Essentially, the heart is unable to generate the high velocities that you usually see in other patients. Because of this, your cardiologist needs to look very carefully and make sure that you don't have severe aortic stenosis once the valve looks calcified. In terms of treatment, in general, we recommend the percutaneous approach. So instead of open heart surgery, we would recommend doing this with catheters and replacing the valve with something called a TAVR, which is very effective. But patients with severe aortic stenosis and amyloid will usually benefit from TAVR. The symptoms will also get better, similar to other patient cohorts. So going back to this initial slide, I want to emphasize, and I can't emphasize enough, how important that it is to make an early diagnosis. So again, we really want to identify TTR amyloid in its preclinical or early clinical phase. The idea is if you can identify patients early enough, you can treat them with diuretics and stabilizers, and they'll never progress to worsening heart failure, and you don't have to worry about worsening heart failure and worsening heart failure symptoms. So I think educational webinars such as this are really critical, as well as education for the community. So a lot of these efforts really need to be heavily underscored. If you do end up developing advanced heart failure, heart transplant is an effective option, as Dr. Lyle touched on. But this is an analysis looking at UNOS data. UNOS is the governing agency for heart transplant in the United States. But in the older era, patients with amyloid in blue did worse than patients without amyloid in red. However, in the more contemporary era, patients with amyloid do just as well as other patients, largely due to patient selection. So heart transplant is a very good option for those that need it. But I think, again, this is only for patients with end-stage amyloid. And I think the point of the field is really to identify patients earlier so we never get to this stage. So what are take-home points? In summary, what do we know? Loop diuretics can alleviate symptoms because it decongests the lungs. So if you have fluid overload, you should be put on loop diuretics. What about other heart failure therapies? Beta blockers, it remains controversial. You can use this at low doses for those with LV dysfunction, but you really need to individualize this because it's not well tolerated in patients with advanced disease. ACE inhibitors and ARBs, the data for this is mixed. In general, we don't recommend the use of this routinely. MRAs such as spironolactone are beneficial and should be used. Heart transplant can be used for severe cases of amyloid. What about arrhythmias? As I mentioned earlier, we should always anticoagulate if you have atrial fibrillation. What about defibrillators? We don't really know the data for this. There's, it's very inconclusive. So this really needs to be individualized. So I think for areas for research, we need more clinical trials looking at these conventional heart failure therapies, as well as the newer therapies such as SGLT2 inhibitors. Touching on them briefly, I would say that even though we don't have any published data, anecdotally, I use this in my patients. It's very effective in decongesting the fluid overload, and it tends to be very well tolerated. I know Matt Maurer has a series of patients that they're, that they're writing up now. And I would say, I think, from secondhand, I've heard that patients appear to benefit from SGLT2 inhibitors. What about treatment of arrhythmias? We need more data on the Watchman device, which really abrogates the need for anticoagulation. Essentially, just closes off the appendage so that you don't have to take long-term blood thinners, but we don't know how effective this is. For those with pacemakers, resynchronization may be beneficial, but we also need more data on this. And we also need data on who benefits from defibrillators. I'm going to end here and just mention that there was a recent 2023 American College of Cardiology expert consensus decision pathway for managing patients with cardiac amyloid. It's very comprehensive and touches across the full spectrum of systemic disease. I highly encourage you to look through this because it really covers a lot of the aspects of ATTR amyloid which are being talked about today. This is a QR code. You can scan this, or if you type this into Google, it's an open access document, so all of you can access this readily. I thank you very much for your attention, and I will pass this on to Dr. Karam.
Thank you so much, Dr. Cheng. As always, we learn something new every time we have one of these. This is wonderful. And we learn more than one thing new, that's for sure. And there'll be lots of questions for you later. Right. And now we will go on to hear about neuropathy symptom management with Dr. Karam. Dr. Karam, take it away.
Thank you, Muriel, and thank you all for coming here today. So I'll be discussing a neurological complication of ATTR amyloidosis. As you know, ATTR amyloidosis is a multi-organ disease, so the heart is obviously affected in many people. The nerves are affected in many people and other organs as well. This is the outline of this talk today. We're going to start with an overview of the neurological system to understand a little bit how the nerves in the brain and the spine function. Then we'll try to explain a little bit how amyloid damages the nerve, the signs that people present when they have neurological involvement. How do we detect amyloidosis, the challenges, and I'll just briefly touch on the treatment strategies since we've already heard from Dr. Lyle and Dr. Cheng about how to treat patients. So this is the nervous system. It comprises what we call the central nervous system, which is the brain and the spinal cord. And then there is a peripheral nervous system, which is the nerves that kind of leave the spine, going down to the hands, to the feet, to the guts. And when they go to the guts and the heart and the lungs, etc., we call them autonomic nervous system. And we'll expand on this a little bit more later. But think about this as electrical wires. So if you have a problem down at the foot, you're going to feel it. But if you also have a problem at the spine, it is a little bit hard for your brain to determine, is this coming from the spine or from the nerve? So we have to investigate this. And that's what the neurologists try to do, to try to localize where the problem is, because they can feel exactly the same way if you have a pinched nerve at your back or if you have amyloidosis in your nerve at your foot. Another thing that you will hear neurologists talk about is axonal damage to the nerve versus demyelinating damage to the nerve. And think again about the nerve as an electrical wire, and you have the insulation, which is in this case the myelin, and the metal inside, which is the axon. The problem is if you have axonal damage, nerve regeneration is very difficult, whereas if you just have a myelin problem, the regeneration is much more possible and doable. Unfortunately, in amyloidosis, the nerve damage is axonal in type. So if you have a lot of axonal damage, you may not necessarily grow that nerve back once it has been damaged, even if you control the underlying problem. So you heard that the TTR is mainly produced by the liver. This is very important because the very effective drug that we use currently target the liver. But the TTR is also produced by other organs. The eye, for example, the brain produces TTR, and you can have amyloid in the brain and in the eye and hearing as well. So unfortunately, the current treatment that we have don't target the brain or the eye. You've seen these pictures many times. It's very important to understand how the disease starts and what organs are usually involved and what to target. If you do, this is a nerve biopsy, this is a picture of a nerve biopsy in amyloid. And as you can see, the red spots here are amyloid. It is a little bit difficult for me to understand how that causes the neuropathy because you still have nerve around it. So the idea is this just toxicity of the amyloid, meaning even if they're not depositing here, are they causing damage just by circulating in the blood? That's a very good question and does have implication on diagnosis and treatment, in my opinion. This is another picture, shows you the amyloid just depositing around the blood vessel in the nerve. So again, that could cause, I guess, neuropathy, but by occluding the blood flow to the nerve. So that is one possibility of how amyloid, but most of the time we don't really see these type of abnormalities. We just see a speckle of amyloid in a nerve. So you already know that you are expert in ATTR. It comes in two flavors. It comes in the hereditary, where you have a genetic variant that you have inherited either from your mother or father. Every now and then you have a spontaneous variant, and you have a 50% chance of passing this to your kids. And then we also have the wild type ATTR, which there's no genetic mutation or variants, but for some reason, people just, as they get older, develop amyloid. So what are the neurological signs? In hATTR, it's a little bit difficult than wild type TTR. hATTR or hereditary ATTR or familial amyloid polyneuropathy, and now the novel nomenclature, you may hear people talking about TTRV for variant. The symptoms usually start in the feet. So people start having numbness, tingling, burning sensation in the toes. And as the disease progresses, the symptoms will spread more proximally, meaning that the ball of the feet is going to be affected. Then the symptoms are going to spread to the top of the foot, then the ankle, and then to the mid-shin. And usually by the time they reach the mid-shin, you may have some symptoms in your fingertips. Those sensory symptoms are numbness, burning sensation, prickling sensation, pain to light touch, feeling like you have socks or walking on cottons or stones, balance difficulties when symptoms become more advanced. You may have weakness in the toes and then eventually at the foot and difficulty standing on your heels or tips. And we also mentioned that the nerve going to your GI tract, to your stomach, to your bladder and bowel and heart and blood vessel, etc., can be affected. And I'm going to expand a little bit on this later because it's a very important symptom that bothers a lot of our patients. So how do we diagnose neuropathy? Usually the patient volunteers these symptoms and they are investigated by the neurologist. However, we know that a lot of time patient may not necessarily have a lot of symptoms or may not be aware, and then our cardiology colleagues will send the patient to us, and we do find that there's neuropathy. And this is important because currently it has implication on how we treat people. There's a very good test that we like to do. It's not very pleasant, but it's very useful and helpful. It's called nerve conduction study, where we stimulate the nerve at one point and record along the nerve to determine if there's nerve damage or not. We can also do a skin biopsy to look under the very small nerves in the skin, or do a sural nerve biopsy, which is a large nerve, when we take a piece of that, looking under the microscope to see if there's any evidence of amyloidosis. How about autonomic dysfunction? These symptoms are very common. Unfortunately, a lot of time they may be neglected or people don't want to talk about them, but they can affect quality of life much more than the neuropathy or the heart involvement. So what are these symptoms? Trouble with erection in men, diarrhea, constipation, and even worse, having difficulty holding the stool. So you have soiling. Early satiety, you eat a couple of bites and you feel full early. You may have nausea, and you may have vomiting and regurgitation of indigested food. And all of this will lead to weight loss and cachexia, and can be really life-threatening if you don't eat very well. Orthostatic hypotension is another major problem in amyloidosis, where people, when they stand up, they feel lightheaded. They feel like they have pressure on their neck and on their shoulders. They feel dizzy, and if the symptoms or the drop in blood pressure is severe enough, they may faint and injure themselves when they pass out and drop on the floor. And then, of course, heat intolerance, because your body is not sweating very well, so it cannot control your temperature. And especially now in the summer, this may become more and more of a problem. Orthostatic hypotension, I mentioned that. It's very easy to detect this. All you have to do is sit down or lay down for a few minutes, take your blood pressure while you're laying down, and then stand up, wait a minute after standing up, and take your blood pressure again. And you can take it even at 3 minutes and 5 minutes if you want to be very thorough. And if you have a drop pressure in your systolic blood pressure, which is the highest number of 20 points or more, that indicates that there is orthostatic hypotension. And it is a manageable condition. It's a little bit difficult to manage, but we can manage it with a lot of teaching, and we even have medication if symptoms are bad enough. And it's important to detect it, because sometimes when you're sitting down, your body's trying to compensate by actually elevating the blood pressure, which causes supine hypertension, which we don't really need. And then what happens is that your doctor, who most of the time take your blood pressure sitting, may push more and more blood pressure medication on you, and that will give you a worsening of your symptoms and fainting. Carpal tunnel syndrome, we've heard about this. It's a very common problem among the general population, but it's even more common in people with amyloidosis. And it can be the first symptom of amyloidosis. And what happened, you have amyloid depositing in the ligaments, and you have a nerve called the median nerve that goes to your first 3-digit, thumb, index, and middle finger, a little bit to the fourth finger. And when you have that, if you're holding a phone or a book or sleeping at night, and you turn your wrist while you're sleeping and bend them, then you'll wake up with numbness in the hands. And as symptoms progress, they will become more persistent. It is a treatable condition, and the earlier you treat it, the better. This is a study that is now a few years old. We looked at what are the first manifestation of the disease, and carpal tunnel syndrome happens in about 50% as first symptom. Then you can have autonomic dysfunction, heart, and neuropathy. And a lot of time in these patients with amyloidosis, when you have carpal tunnel syndrome, if you really ask carefully the patient, they may have some symptoms of heart involvement or autonomic involvement or neuropathy. However, in about 40%, the only thing that they have is carpal tunnel syndrome, which causes obviously a problem because you treat that with amyloid suppression. It's hard to really do that. And we usually think about it carefully, and we don't. So I'm going to try to move on a little bit quicker because I'm thinking a little bit over time. Spinal stenosis is kind of similar to carpal tunnel syndrome, where you have tightening in your spine, which will compresses the nerve roots, and that will give you numbness and tingling and pain in the lower back and in that shoots down to the feet. And this is treatable with physical therapy, injection, medication, and if things are really bad, you can have surgery, and that usually relieves the pressure on the nerves. You can have the position of the amyloid in the eyes and have opacities and floaters, glaucoma, and so forth. You can also have amyloidosis in the brain, which will lead to stroke-like episode and can even manifest as bleeding. The central nervous system or the brain issue are probably become more common because we are now targeting the liver and the amyloid that is, or the TTR that is in the blood. But a lot of the medication that we have right now don't go to the brain. So we have to keep a good eye and close eye on these symptoms that can manifest in the brain. We can image the amyloid in the brain, by the way. So how do we detect it? Biopsies, imaging, this is what we do. You probably have all of these tests done. PYP scan is a really good test if done carefully, but also fat aspirate, muscle biopsy, nerve biopsy. Remember that just the biopsy that doesn't find abnormalities does not mean that you don't have amyloidosis. So you can still have amyloidosis, and you may have to do multiple biopsies to prove that that is the case. The challenges is that many patients are misdiagnosed. It is, at the end of the day, is a rare disease. So people usually think about things that are more common before they think about amyloidosis. And people can be diagnosed with many different disorders. This is something we wrote about a few years ago as well. The other challenge that we have is that many people that we currently follow actually have just the variant, but don't have symptoms yet. And we don't have very good guidelines on how to manage these patients. And at this time, the treatment of these patients may vary. So the treatment strategy, we have treatment that are specific to TTR, which Dr. Lyle talked about, and treatment of the symptoms. Dr. Cheng talked about the cardiac symptoms. I'll talk a little bit more about the other symptoms. Remember that the damage of the organs, as you can see in this study with the Apollo and then the open label, is that once you don't treat patient for a few years, you have irreversible damage that even when you start treatment may not necessarily recover. So that's why we're always trying to start treatment as early as possible. These are the medications that have already been discussed, so I won't be spending a lot of time on those. But I was asked specifically to talk about vutrisiran and patisiran. So patisiran is the IV medication called also Onpattro, where we had to pre-medicate people with steroids, antihistamine, antacid before doing the infusion. And then you do the infusion and you repeat the infusion every 3 weeks. This was a very good drug, but now we have an even better version, which is vutrisiran. The good thing about this drug is that you do it once every 3 months. It's an injection under the skin, and you do not necessarily have to pre-medicate. So we don't give steroids or antihistaminic prior to the medication. So these drugs, the studies have found that they do suppress the TTR to the same degree, and vutrisiran maybe suppresses even more than patisiran. So that's why I personally do like this drug. Because I think it's efficacious although I've heard from some colleagues that when patients switch from Onpattro to vutrisiran, they have more symptoms. So the question is it really related to the drug, or just the symptoms are not very well controlled and they need additional medication for their pain, for example, etc. So so far, I still think this is a good drug. What about combination therapy? A lot of our patients end up on both medication, meaning stabilizer and a silencer, like for example vutrisiran and tafamidis or diflunisal. And we don't really know if that's a good thing or not. We have studied this and we have found that overall it's safe. So there's no really increase in problems with that. But our follow-up was on average about a year, because again, these are new drugs and we didn't really find a difference that's significant in people who are on both. Now, looking at these symptoms specifically, we have many different medication to control the symptoms and not just the disease. So for example, if you have pain in your feet from the neuropathy, some of the medication that we may use are duloxetine, which is a Cymbalta, gabapentin, which is the Neurontin, and we may sometimes use a combination of those. There's also other medication that we can use as well. Back pain is a common issue. We try a lot of physical therapy, local injection, and if that doesn't help, you can do surgery. In refractory pain, we can try spinal cord stimulator. I'm not opposed to trying alternative therapies such as local creams or acupuncture, etc. For the carpal tunnel syndrome, wrist splint, especially at night, can be a good thing, especially when the symptoms are mild. But as the symptoms progress, then you may use surgery. For the diarrhea, loperamide, opium tincture. For gastroparesis, you can use Reglan, Mastodon, which also works a little bit on the blood pressure if you're having issue with orthostatic hypotension. Midodrine, droxidopa. For constipation, fibers, Miralax, change in diet, etc. And for erectile dysfunction, there are oral medication to try to help with those. So I'm sorry, I think we're running a little bit late, but I will stop here and I will pass it back to Muriel.
Thank you, Dr. Karam. I really appreciate it. You didn't have to rush, really. It was really important, and I'm so glad we got to hear it. And we'll hear from you more when we do the Q&A, but this is what we'll do right now. We'll have the Q&A after our break. We'll also hear from Paula after the break. She's got some financial assistance information she wants to share with us. So we'll take a really quick, let's say 5-minute break. Okay, and then we'll come back and we'll hear from Paula and we'll have the Q&A session. Okay, so 5-minute break for everyone. Okay, we're back. And we'll have our 3 brilliant physicians. And we'll start, oh, well, before we do, Paula, I know you're actually able to share where there's actually money for people right now in copay. So let's go right to you directly and please take a couple of minutes and tell us all about all the money that people can get.
Yes, this is kind of exciting right now because there is money available. I checked again last night after they all closed and money was still showing as available. So, well, let's hit on genetic testing first too, since that's my slide here. For those of you that need to have genetic testing done for your family members, you can contact Alnylam Act or ATTR Compass to set up free testing for your family members. I have put these links in the chat already. You can go there and see them and copy them over for yourself to save. For financial assistance, for those of you that are not yet on Medicare, you need to go to vendalink.com, and those of you that are on welfare, that are on Medicare as well, can go to the vendalink.com website and find out about the financial assistance. Medicare patients are not able to qualify for the copay assistance cards that they have, but if you are not on Medicare yet, you can qualify for one of those cards and get your drugs for free through that assistance program. So be sure to go there to look at that, to sign up for it. Our other drugs are covered under Part A Medicare, so we don't have to worry about those as much. Some people have Amvuttra being charged to them under Part D, which is not correct. I don't know how many people are still having that problem, but you need to talk to Alnylam Assist if you are having that problem with your Amvuttra injections. Okay, the good stuff, the money. The foundations that have funds open right now are Healthwell Foundation. Their amyloidosis fund pays up to $8,000 per year. They also have a cardiomyopathy fund that will pay $10,000 per year if you are on Medicare. The cardiomyopathy fund also covers the amyloidosis drugs. I did not know that until just a few months ago. So you may want to go for that fund if you've got a diagnosis of cardiomyopathy, since it's $2,000 a year more. You have to be at or below 500% of the poverty level to be able to qualify for these assistance programs. But if you're right on the borderline of the threshold for that, for your income, call them anyway, because if you live in an area where the cost of living is higher, they do make adjustments for that. So you may actually be able to qualify for a little bit more than what they state on their website is available. The Patient Access Network, that fund is open, pays $8,500 per year. And again, you have to be at the 500% poverty level. That one is run by the PAN Foundation, which is Patient Access Network. That's what that stands for. The Assistance Fund also has an amyloidosis fund, but it is not open right now. If you want to try to qualify for that one, you have to sign up for the waiting list. And that waiting list, you must reapply for it each calendar year in order to be on that list. And they will contact you once their funds open up. You can you'll get an email from them stating that you can go in now and try to apply for it. But these funds, we never know when they're going to close. So, you know, act quickly. Do try to contact them Monday if you can. You can call them or you can set this up online. I did see that one of these is going to be closed on Tuesday, I believe it is. It's listed on their website, so you may have to apply online that day. Okay, I was talking about the percentage of poverty level that you need to be at to qualify. This chart here will show you that. Over here on the left-hand side, we've got a column that shows how many people are in your household. And then you go over to the column. If you're in the 48 states, you go to the column, you know, for 500%, and you can make $98,600 and qualify for those, for either of those funds. If you're in Alaska, you need to look at the yellowish looking block, or green if you're in Hawaii. I do know we have some patients in Hawaii. They can make $113,400 for a family of two. So, you know, like I said, be sure to call them if you are close to that threshold and see if there is an allowance for your area that you live in. The Fund Finder app is something that you should also sign up for. This is run by the PAN Foundation. You will receive an email. If these funds have been closed, you will get an email from them stating that it has opened back up, and you can then go and apply, or it will tell you if it is for renewal patients only, or if it is open to new applications. So I suggest you sign up for this, and it gives you a little heads up, you know, when these funds do open. You don't have to go in every day and check them to see if they've opened up, if they've been closed. But that is the help that is out there right now. So go for it quickly, because it could be gone Monday afternoon. I never know. I did tell someone this past week that a fund was open, and they emailed me back and said, no, it's not open. And I had checked before I had emailed them and said that it was open. And by the time they went online and looked, it had closed. So you got to be quick, folks, but go for this money if you're able to. You know, it's out there for you, and it will help with these copays that everyone has to try to come up with for some of their drugs.
Thank you so much. Strike while the iron is hot, everyone, right? Okay.
Yes.
Now let's get to our questions, because there are a lot of them. Okay. This patient would like to ask Dr. Lyle and or Dr. Cheng if they prescribe. We'll ask Dr. Cheng first. Okay. Do you prescribe Jardiance for cardiac amyloid patients with heart failure? If you do, what outcomes have you seen? Side effects? Blah, 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 blah.
Yeah, yeah, I think that's a good question. So Jardiance is a SGLT2 inhibitor. In general, we think it's a class effect. So as you know, Jardiance is empagliflozin, but there's also dapagliflozin, which is Farxiga, and there's sotagliflozin. There's a number of drugs in that class. In general, for any heart failure, it's been shown to be very effective. Specific to TTR amyloid, there's actually no data that I'm aware of on this. I would say anecdotally, I do give it to my patients and they tolerate it well. Theoretically, it has some diuretic properties, so it'll get rid of excess fluid. But also, there's some data suggesting it may lower the lung pressures, which is very helpful in patients with TTR amyloid where the heart is very stiff. In terms of side effects, it's going to be the same for other patients. It's generally well tolerated. The concerns are there's some risk for worsening urinary tract infections if you have a history of it, because it results in glycosuria where you urinate out blood sugar. And then there is some weight loss, which can be good or bad depending on whether you're trying to lose weight or not. But in general, it's very well tolerated. I do prescribe it. There's not much data. And I was kind of alluding to, I think some groups have some data that's probably coming out soon, suggesting that it's probably something to be considered. But as of now, I would say, you can use it, but not enough data to recommend it systematically.
And we'll assume that Dr. Lyle agrees with you because of time. So unless she pipes in and says she doesn't agree. Okay. And one quickie question, follow up to that is there a creatinine level that a patient would have that would cause you to say no to Jardiance?
Yeah, I mean, we usually use GFR for that. I think from the original studies, it's usually a GFR cutoff of 30 or 35, depending on which SGLT2 inhibitor you're looking at. So there were some thresholds that you have to consider.
Okay, thank you. Dr. Karam, you mentioned this in your presentation. You mentioned some other treatments, but skipping those, do you have any other dietary or natural recommendations for amyloidosis? Now, this would not be in, we have people that want to use natural remedies in substitute for the actual, treatments that are approved by the FDA. But this is, in addition to that, we'll assume.
Yeah, I mean, obviously common sense, healthy, and a healthy, well-balanced diet and stay away from processed food. I mean, I think it's like anything in nutrition, you have to be careful and but at the same time you have to, if people have a lot of weight loss, then that's not just because they're taking the diuretic, then that's obviously something we have to keep in mind and try to work on the GI tract to make sure that they're absorbing the correct nutrients. You have to remember, if people are deficient in, for example, vitamin B12, that can adds up to their neuropathy, or if their patients are diabetic and they're not controlling their sugar, that can make also the neuropathy worse. So we always have to keep an eye on these things as well. Okay,
thank you. Okay, to Dr. Lyle, I've been diagnosed with wild type. I've been taking Vindamax. Is there any way to determine if the proteins have been stopped from misfolding? In other words, how do we measure that the patient is doing better other than him still being alive?
Yeah, no, it's a great question. How do we measure and how do we look at disease progression? So as I alluded to, especially with imaging studies, if people are having worsening clinical symptoms, it's very appropriate to repeat echoes and repeat MRIs if they're having a clinical deterioration. Otherwise, we don't have a lot of evidence in terms of those imaging studies to follow disease progression as of right now. So repeating nuclear scans and cardiac MRIs just to follow disease progression, we don't have a lot of evidence that that's of a lot of benefit. Muriel, as you kind of hinted at, we often go with clinical symptoms. How are they doing? Are they feeling stable? Has there been stability in their disease? In terms of biomarkers, sometimes we will get the TTR levels. If someone has initially diagnosed without TTR treatment, especially if they have advanced disease, they'll have lower TTR levels. And then when they're on a stabilizer, we see that the TTR levels are higher and increase. But in terms of clinical assessment and utility, we still don't know. So really, it's often I go by clinical symptoms and how the patient is doing.
Great, thank you. We're going to hear from Spencer's, and Attralus soon about this, the imaging that they're doing from the University of Tennessee, Dr. Wells thing. But this person wants to know, how often do you recommend PYP or cardiac checkup to see if there are no deposits? In other words, are there any scans that are being used currently other than the ones in clinical trials that can tell whether a patient's improving, an MRI or an echo or something that shows you're getting better?
Yeah, exactly. So right now, all just in clinical trials in terms of looking at improvement. So in just clinical practice, I don't typically follow with imaging studies to look at reversibility of disease, but hopefully with clinical trials, we'll have a better idea about ways to assess that.
Thank you. Oh, Dr. Cheng, this patient says that they have wild type, they've had open heart surgery, but their PYP tests have always been negative. I don't know how they were maybe they were diagnosed with a biopsy and that's how they were, but their PYP tests are negative. And so they're not eligible for other trials. Do they use PYP tests in trials and not biopsies, or how does that work?
Yeah, I think that's a good question. It might be helpful to get a little bit more information, sort of to frame the question. But I don't know if they're referring to TTR deposits in the heart on surgery, or they're referring to TTR deposits elsewhere. I mean, I think the scenario where we see this a lot nowadays is people who get, for example, carpal tunnel surgery, and they have TTR deposits in the tenosynovial tendon on staining. But when you look for it in the heart, you don't find it with a PYP or other information. If you and for those patients, it's a little bit unclear what the interval of follow-up should be. I mean, the original data came from Moz Hanna's group at Cleveland Clinic. And talking to them directly, they say, it can sometimes take years for there to be cardiac manifestations. So the routine follow-up for those patients is not clear. If there are TTR deposits directly in the heart, it takes a certain burden before the PYP will light up. I think a lot of trials have criteria where you have to meet a certain threshold of being sick before you can be enrolled, because most trials are going to be powered because they want to show a difference. So for example, not necessarily based on PYP, but I know for some of the studies recently, people who had normal BNPs had trouble getting into the studies because those felt they weren't sick enough. So I think it's a balance. I mean, you want patients to get into studies so it could potentially benefit, but you also need enough sort of endpoints for it to power the studies. So I think it's a balance between the two.
Thank you. Okay, this patient wants to know about the medication Entresto. And they want our heart failure medications such as Entresto and blood pressure medications contraindicated for cardiac amyloidosis. And this was covered in our presentation, but maybe you could go over that one more time for someone who might not have been here to hear that.
Yeah, so Entresto is sacubitril valsartan. So what it is, it's an ARB. It's a angiotensin receptor blocker, but it's bound to neprilysin inhibitor, which is the sacubitril, which is a unique component of it. There's really, as far as I know, I have not seen any data specific to Entresto and TTR amyloid. For ACE inhibitors and ARBs, which is very similar to Entresto, but lacks that neprilysin inhibitor component, all of the studies so far have not shown any benefit. So we don't routinely recommend it. And because of that, we do not routinely recommend Entresto because there's not been any data showing any benefits. In terms of the risk for low blood pressures, that is certainly a risk. because of the pressure volume loop relationship and the alterations. There is what we call ventricular vascular decoupling, where essentially normally when you stand up, the heart and the peripheral vasculature is supposed to recognize each other, and the peripheral vasculature will clamp down so you get enough blood to your brain. In TTR amyloid, sometimes that's decoupled, and because if you change positions quickly, it'll make you dizzy. And if you put someone on these drugs like Entresto, it can actually worsen that.
Okay. Dr. Karam, this gentleman has wild type, and a neurologist told him that he has symptoms of Parkinson's disease. And he wants to know if Parkinson's can be caused by ATTR wild type, or is it just the symptoms from the amyloid? Kind of a convoluted question.
Yeah, that's a good question. I mean, so people can have, multiple conditions, unfortunately, and people can have Parkinson and wild type amyloid, and they're not really related, but they're just both present in this unfortunate patient.
Right. People tend to think that they won't get any other diseases if they have amyloidosis, and that unfortunately is not true. Okay, Dr. Lyle, why does my husband's NT-proBNP numbers go up and down? He has V122I cardiac amyloidosis and currently takes Vindamax.
Yeah, that's a great question. So an NT-proBNP, it's a biomarker that we use to kind of assess for heart failure, but we see variability. So if we were to check an NT-proBNP essentially every day on someone, we would get up and down variable. I do check an NT-proBNP as I see patients if there's a clinical worsening or kind of on a 6 month to 1 year basis, and we're looking more at just kind of stability and progression. But it's very common to have minor ups and downs depending on what their volume status is at the time, and it might not even be of really any clinical relevance if it's just a small change.
Thank you. Hey, Dr. Cheng, my husband has V122I cardiac. When I listen to these seminars, the cardiologist says that with amyloidosis, there is preserved ejection fraction. This is not true for my husband. He has reduced ejection fraction, 40% at his last checkup. Is this normal for that type of variant he has? Is there anything that should be done for this besides taking Vindamax, spironolactone, and Xarelto? Thank you.
Yeah, I think that's a very good question. So, I mean, I think the traditional paradigm for TTR amyloid, especially with earlier diagnosis, initially deposits in the extracellular space, and you get the thickened heart and you get preserved ejection fraction initially, where the problem is the heart just thick, it's stiff. It doesn't contract well because it's thick and stiff, and that leads to heart failure. Over time, you can actually develop LV dysfunction where the heart function starts to drop, such as ejection fraction of 40%. That is well recognized, which can worsen over time. What I always advocate for in our patients is if you've been stable initially and you have a sudden drop in ejection fraction, you always want to rule out other causes. The TTR amyloid can cause a drop if it's progressive, but you want to make sure there's not something else going on. For example, coronary artery disease or anything else. In terms of treatment of the LV dysfunction, you sort of use the conventional heart failure therapy model where you mentioned spironolactone diuretics. According to UK data, low-dose beta blockers such as bisoprolol 2.5 milligrams a day may be beneficial, but again, that's somewhat controversial. You could consider that based on a recent study. Besides that, there's not much else. I think the treatment is really to treat the underlying cause, which is stabilization of the TTR process to prevent it from worsening. And hopefully with emerging degraders, that may also improve things.
Thank you. Dr. Karam, this person has been diagnosed with ATTR familial amyloidosis, suffering from quite a few symptoms: bilateral carpal tunnel, radiculopathy, nails receding and falling off. EMG shows lots of damage to the nerves, has had quite a few trigger finger surgeries, stabbing pains, intense burning in hands. We can just go on and on here. Okay. And the patient says that the doctor is reluctant to treat because the scans show no amyloid in their left arm or heart. I don't know what kind of scans they're using. Maybe, the University of Tennessee scans, I'm not sure. Is that standard procedure for someone at my stage of amyloid?
Yeah, I mean, it's obviously there's organ damage here, and I think treatment is indicated. I don't understand why, if the imaging doesn't show it, it doesn't mean that the amyloid is not there. I mean, especially if they have already neuropathy and they have variants. So so that's the question, right? Like, why aren't they be treated? I don't.
Right. They need a second opinion, maybe?
That would be advisable, yes.
Okay. Okay, while we have you, some patients that were on Onpattro and have switched to Amvuttra are seeing an increase of neuropathy issues and overall decline in how they're feeling. Is it possible that the time gap of every 3 months between Amvuttra shots is too long and should be explored? And this is a two-part question. Since switching to Amvuttra, I've experienced a significant increase of fluid buildup in the pleural cavity around both lungs, resulting in difficulty in breathing and required thoracentesis. In 1 year, I've gone from requiring it 2 times per year to requiring it 3 times a year. Could there be a correlation between the drug and fluid condition? So basically, this person is saying that they're doing worse on Amvuttra than they were on Onpattro. Do you hear of this? Is this patient stating something that's been heard before?
So I heard it indirectly. I haven't heard it from any of my patients. I've have over a dozen or plus more patients who switched from Onpattro to Amvuttra. They're all very happy. You have to realize that there are, these drugs, number one, don't stop the progression of the disease. Number two, we have symptoms. So fluid retention, for example, can be caused by heart issue, and they need to be adjusting their cardiac medication, for example, or the diuretic. So it's not necessarily that the drug is not working, it just needs that there's another thing that they need to focus on than the cardiologist. The other thing is that when you have pleural effusion, this is a complicated issue, and it's not really commonly seen in hATTR. So the question is this coming from something else? So before I say that the drug are not working, I would be careful making sure there's nothing else going on. The other issue that we have to think about is when people say that the neuropathy is getting worse, is it just the pain is not under control, or is it really a loss of function, progression of the disease? Because we know that the symptoms of pain can fluctuate, and we need to adjust the pain medication, but the progression of the disease is obviously something that we worry about. The trials that were looked at Amvuttra showed very nicely that they persistently reduced the TTR by almost 90%, which is even a little bit better than what Onpattro showed. So, and the idea is that we reduce the TTR, and that's how we improve the disease and we lessen the burden of amyloid. So I don't have a very logical explanation of why people are getting worse. Obviously, if this is something that keeps happening and more patients report on it, I think it's important to look at it. But at this point, I don't have any evidence that one is better than the other.
Okay. Dr. Lyle, Dr. Cheng, you want to weigh in on this? Have you heard this as well, or is this?
Anecdotally, my patients who have switched have not complained of this yet.
Yeah, I was going to say, interestingly, I have a number of patients after they switch, what they notice is they start to have progression of their neuropathy and fatigue immediately prior to their next dose, and it tends to stabilize subsequently. So I think there may be some question about whether there really is, whether you get a steady state over the 3 months between doses. It's something that should probably be explored in some way to determine whether maybe the drug starts to wear off before that 3-month time point.
So, yeah, I mean, one thing that I've started recently doing that I didn't used to do in the past is measure the TTR level in the blood. So that would give us a good idea. And the test that you can ask your doctor to look for is called prealbumin. So that's the old name of the transthyretin drug, and it's available and not expensive. You can do it in any lab. And so far, whenever I have patient on Amvuttra, the suppression is really dramatic. So, but that's something I guess you can look at. And if the levels are high, so maybe the drug is not working very well. But I would be very surprised if that is the case.
Okay, thank you. Okay, Dr. Lyle, What percentage of patients who have hearts have amyloid fibrils don't go on to develop amyloidosis? What percentage of patients whose hearts have amyloid fibrils don't go on to develop amyloidosis wild type? That's a confusing question. Do you understand that?
Yeah, I guess I'm not quite sure. I can try to answer it in two ways. Sometimes we think about, as I mentioned, we don't know the true prevalence of wild type TTR. So there have been autopsy studies that show that wild type TTR deposits, up to 40% of patients over the age of 90 actually have wild type TTR deposits. But a lot of those patients might not have manifested symptoms of heart failure. So maybe that kind of addresses that. And then also, I guess, the question of carriers. So if they have a mutation and they're a carrier, if they go on to develop, and it's thought to be anywhere up to 20% of patients who might go forward to have manifestations of the disease. However, that's when we do screening. So I don't know if I answered that question, but maybe the question of possible asymptomatic carriers, what percentage of patients develop the disease in the future, if that's what they were getting at.
I'm not quite sure, because they said wild type, not hereditary.
Yeah.
So
I'm not
it's
sure if
kinda
I answered
confusing.
that, but
Okay, we'll go on to the next one. What is we had a few questions about life expectancy, so we'll throw this one at you. Okay.
sure.
What is the life expectancy in years for a patient diagnosed with wild type TTR?
Yeah, so that's a great question. And I didn't touch on that in my presentation, but we do have risk stratification and staging criteria. So just kind of median survival at time of diagnosis for hereditary TTR cardiomyopathy is around 2.5 years, but for wild type 3.5 to 5, medium from the time of diagnosis. But the staging criteria that we use, the Mayo Clinic staging system actually is for wild type TTR. We look at biomarkers, troponin and NT-proBNP, and those stages are stage 1, 2, and 3, with stage 1 being you don't meet the threshold or cutoff of those biomarkers being high, and that's around 66 months median survival.
But that's without treatment, right?
That's without treatment, exactly. And so we need more updated data in terms of once someone has been started on treatment, kind of where their prognosis is. So that's further data is needed.
Okay. A lot of things. We've read an article in the June 8th, 2023 issue of the New England Journal of Medicine entitled Antibody Associated Reversal of ATTR Amyloidosis Related Cardiomyopathy. Does the panel have any comments on this article?
Yeah, and I briefly mentioned that in my presentation. So interesting, 3 patients, it was an observational study, just a correspondence. So very interesting, but I don't think I have any further comments other than potentially things to look at in the future, if Dr. Cheng has other thoughts.
Yeah, no, I mean, I agree with Dr. Lyle. I mean, I think from understanding those patients, a spontaneous regression of their TTR over time, which I think it's very difficult to really sort of put that into context. Where it may be helpful is if these patients had, for example, antibodies, particular antibodies that were circulating that other individuals don't have. It may allow for therapeutic target, and I think where it adds a lot of excitement is sort of these emerging fibril degrader antibodies that are being developed. For example, PRX004, NI006. And others, I think it's if this works even naturally, the question is whether these newer drugs may be effective also. I think it sort of lends credence to that pathway of these newer drugs.
Okay. Now we have Dr. Karam. Okay. This is the heart and liver transplant recipient from 2008, and they're doing well. They were on Tegsedi for 2 years, on Patro for 2.5 years, and they've had their second Amvuttra injection. Their neuropathy has steadily progressed. And we've heard this with organ transplant patients before. They'll be 73 years old this year and would like, so wants to know if they'd be a candidate for nerve repair research.
Yeah, so that's interesting. I mean, they are obviously on the state-of-the-art treatment. They've already got their transplant and they're getting silencer. I think we have to always be careful and look for other causes. There's hundreds of reasons why people get neuropathy, And I think the first thing to do is to make sure there's nothing else going on that is causing the neuropathy. So that's number one. Number two, if everything else is ruled out, unfortunately, I think they're already on many medication. One could consider, I guess, adding diflunisal, for example, on top of the other drugs. But now the idea is that we're really, this is uncharted territory and we don't really know. Nerve repair, that would be amazing. Unfortunately, there's nothing going on in nerve repair that is currently available.
Is there any connection between amyloid deposits in the heart and nervous system and amyloid deposits in the brain? Dr. Karam.
So yeah, as I mentioned, unfortunately, amyloid is being produced, or the TTR at least, is being produced not only by the liver and being secreted in the blood, but also being produced in the brain and in the eye. So there is definitely, and we know we have families that unfortunately the amyloid manifest as brain or ocular as a first sign of disease. And obviously, these are very difficult to treat. Dr. Lyle mentioned tolcapone, which is one of the drugs that can penetrate the central nervous system. And that is one thing that we look forward for clinical trial to be done.
Right. We're also told that tafamidis, Vyndamax, penetrates the blood-brain barrier as well. Is that true?
So that is true. The question is it enough? And the answer is I don't know.
Okay. This answers that question. Quite a few people have related questions that go with that. Okay. And then does anyone else have sneezing attacks that can last for up to 5 to 8 sneezes, or is it just me? Interesting. Okay. Anyone want to take that? Dr. Karam, you're elected.
I was waiting for Melissa to Dr. Lyle, and then Dr. Cheng disappeared. So I haven't heard that before. So again, sneezing could have many reasons. So, but that's interesting. I would keep it in mind.
Well, we often hear about people, and there was a question in here I haven't gotten to it yet, but I'll ask you about that because people mentioned the cough, that they have the cough associated, we hear that in the AL and ATTR world. And
cough may have a good explanation. Maybe Dr. Lyle would want to answer that.
Yeah, I think from a cough standpoint, we would be worried about their volume status in terms of if they're having fluid retention in their lungs, causing more heart failure symptoms, particularly when laying down at night. Often our heart failure patients will have a cough, and that's just a need for ongoing diuresis and getting the fluid removed.
And Dr. Karam, the sneezing just reminded me that you've been very interested in sleep apnea and breathing issues relating to amyloidosis. I saw your questions on that recently. Could the sneezing relate to something like that?
That's an interesting idea. I'll keep it in mind. I don't have a very good explanation.
Okay. Question here. Does ATTRV with cardiac involvement emerge as dominant disease when multi-morbidities manifest? 85-year-old frail male diagnosed with ATTRV, on Onpattro, now on Amvuttra, has heart failure, mixed sleep apnea, polyneuropathy, and recently diagnosed with rapidly advancing Parkinson's. Should he continue course for Amvuttra, or in presence of comorbidities diminishing any benefit from it?
Yeah, that's a very difficult question. Again, people can have two problems. I mean, Parkinson is not typically a manifestation of amyloidosis. So the question is there something else going on? I think definitely getting an MRI of the brain whenever there's anything neurological progressing fast is important to make sure there's nothing else going on, especially that amyloidosis can result in bleeding in the brain, for example, or other issues. So I think that's very important to investigate this further. I'm not sure what they mean by dominant disease. TTR is an autosomal dominant disease. And I'm not sure if they are saying that there's more symptoms that they would expect.
Maybe they mean one more important than the other,
Right. Yeah. So, cardiomyopathy, neuropathy, all of those are manifestation of the disease. And some people have more cardiac involvement, some other have more neuropathy, and many of our patients have kind of a mixed phenotype as well. But again, whenever something doesn't really make a lot of sense, I think it's important to investigate further, bring it to the treating doctor, and maybe obtaining additional tests to make sure there's nothing else going on.
Right. A reminder that we're going to hear more about gene editing in a little bit from the Intellia folks, and we're going to hear more about imaging and the Attralus thing from Spencer, because we've got quite a few questions in there that I'm not asking yet. So just so you're not going to be forgotten, just so you know. Okay. And we're going to get to a few more, and then we are going to hear from our pharma folks. So, and then we'll have more Q&A. Okay. My 80-year-old sister has the hereditary TTR gene, but not amyloidosis. I have the ATTR gene and have suffered with amyloidosis for the last 3 years. This person is 74. Okay. My 43-year-old daughter just learned she has the gene. Is there a test my daughter can take to determine if she will suffer from amyloidosis? In other words, she wants to know if is there a test that the daughter can take to see if she's going to actually have active disease like her or inactive disease like her sister? Is there some sort of test that tells us that? Dr. Karam, you're shaking your head no.
No, unfortunately, we don't have that. That's a very interesting concept. I think at some point we will be able to predict who's going to develop the disease or when they're about to develop the disease. But unfortunately, at this point, with our current knowledge and technology, we cannot predict if somebody will develop the disease. So let's just hope for the best, but we have to monitor, obviously with the cardiologist, neurologist, et cetera, depending on the variant that they have, et cetera, maybe once a year, maybe less frequently.
Okay, we do a lot of meetings, and we find that there are some cardiologists out there that we know and love, that if a patient has been diagnosed with the hereditary gene, and they would be about 43 years old, or whatever, that they might start them automatically, even though they're not symptomatic. They might start them on diflunisal if they can tolerate it, because it is an NSAID and comes with its share of issues, but many can tolerate it. And I know there are quite a few that will start them on that, even if they are not symptomatic. So I will ask the three of you, I will go through and I will put you all on the spot. Dr. Lyle, are you one of those cardiologists?
I would say that it depends on the scenario and the patient. I think we don't have any evidence to say for an asymptomatic carrier who has no evidence of disease that putting them on a stabilizer is indicated. However, I think the bigger question is for those patients with subclinical disease. So for example, someone who may have a slightly positive nuclear PYP, but a normal biomarkers, no heart failure symptoms. I think that the question of subclinical disease and stabilization may be more warranted, but I think we definitely need more evidence for the completely asymptomatic carrier.
Very politically correct answer. But,
thank you.
Okay, Dr. Cheng, can we get down to the nitty gritty with you? Have you ever prescribed diflunisal for a patient that was not symptomatic, that had inherited the gene for ATTR?
Yeah, so I think that's a very good question. I mean, I would say big picture, I agree completely with Dr. Lyle. I think the first thing to keep in mind is for the different TTR variants, the penetrance can be highly variable. So there is an ongoing study right now, the SCAN-MP study by Columbia University as well as Boston University, where they're looking at the community of African Americans and Caribbean Americans to really understand the prevalence of TTR, but also the penetrance for V122I specifically. In that study, for example, the penetrance I think was in the initial data was about 35%. So it's actually not that high. Where other variants such as T60 or V30M, the penetrance can be as high as 90% depending on which study you look at. So I mean, I think that's the first question, right? I think you can't treat the different variants the same. Going back to that question, I mean, I have not prescribed diflunisal for someone that's completely asymptomatic with no evidence of disease. However, I think for any genetic carriers, they should be systematically screened. And typically we recommend close screening starting 10 years prior to the development of disease by the family member. So for example, if the mother develops disease at age 70, then the children should start being screened very close to age 60, or if they develop symptoms sooner. And this would entail a baseline PYP, MRI scan, as well as biomarkers, and we tend to do biomarkers and echo annually, at least from a cardiovascular standpoint, and then send them to neurology for neurologic assessments. But once we start to see any signal of disease, for example, rising biomarkers or any degree of neuropathy, then we would initiate diflunisal. And we have done it for patients who, you don't see very much, but their biomarkers started to increase, but not for someone with completely normal, normal stays. Otherwise, only because the penetrance is not consistently that high.
And Dr. Karam, we don't leave you off the hook either.
I'm going to agree with Dr. Lyle and Dr. Cheng. So I have prescribed diflunisal in very specific situation when there are, within just a few years of developing of what their parents have developed the disease, the patient is very anxious. They're really very close to when their parents had the disease, and especially when the disease people. So the answer is yes, but I don't do it systematically. Most of the time I don't do it. Think about it. You have a V122I whose parent maybe developed symptoms at the age of 80, and the patient is right now 30. Do you put them on diflunisal for 50 years? Or 40 years? That doesn't make a lot of sense, right? So we have to be careful with those, and we don't treat unless we have either they're getting really close to where their parents start having symptoms, or they already have some minor symptoms that tell us maybe the disease has already started.
Great, thank you. Okay, Dr. Lyle, and this is a question that comes up a lot at our meeting. What is recommended for exercise? How much physical exertion? I have heart flutter, and a cardiologist is recommending an ablation. Any thoughts on that? So we have it's a two-part question: exercise, physical exertion, and an ablation.
Yep. So the question for exercise first, we typically still recommend, of course, it can differ patient to patient depending on what their circumstances are, but in general, I would still recommend what the American Heart Association recommends for exercise, so 150 minutes of aerobic exercise weekly. The question in terms of the ablation, though, and Dr. Cheng can add additional input, I think that's a little bit of a harder question for atrial fibrillation and atrial flutter. In terms of recurrence, we know that there is a higher rate of recurrence for more of atrial arrhythmias, fibrillation and flutter with more advanced disease. It also kind of varies a little bit if it's a typical atrial flutter and what type of ablation is needed. But sometimes I can consider that ablations for patients with earlier disease, earlier cardiac involvement before more advanced heart involvement. Sometimes we see a high rate of recurrence. So it's more of a risk-benefit discussion that it may be more futile.
Dr. Cheng, you want to add to that?
No, I completely agree with what Dr. Lyle was stating. I think you have to individualize this. I think the first thing is if the individual is asymptomatic, despite having atrial fibrillation, then I generally would not recommend an ablation, because the success rates in patients with ATTR amyloid are lower than the general population, as well as, Dr. Lyle touched on this, but there's a lot of data showing that with progression of disease, the success rates go down even further. So I think you have to be very careful. It can be considered in patients who are highly symptomatic, who have earlier stage disease with high rates for success. For people who are very symptomatic with advanced disease, sometimes we do end up doing AV node ablations, which are a little different. You essentially disconnect the upper from the lower chambers of the heart, but the issue with that is then the individual will become pacemaker dependent. So I think it's a very difficult question, but I think you have to individualize the risk-benefit discussions, keeping in mind that ablation in ATTR amyloid is not as effective as the general population.
Great, thank you. Okay, we often hear about people, especially with the V122I variant, because it's more prevalent, that people will get it both from their mother and father, both, and then they can get it even worse than someone who just got it from their mother or father. But this is the patient that has two different mutations. They inherited V122I from one parent and Val30 Met from another. I know it's rare, but this is and you'll meet this young lady in October in Chicago as well. Okay. Anyway, she wants to know if there's any implications or ramifications of this. How does this impact the treatment choices? Should she be on both, just one? She's having a terrible time coping with symptoms, and she wants to hear from our experts here. So we'll let you go first, Dr. Cheng, and then we'll go to Dr. Karam and Dr. Lyle.
Yeah, so I mean, I think there are some differences because the different variants present at different age groups. So we know the T6 stable present younger than V122I, V30M. It has sort of like a dual age presentation. So I think that's the first thing. In terms of which variant, you have to think about when to start looking for clinical manifestations. In terms of treatment, there's also some differences. Some variants will present more with polyneuropathy, others with more cardiomyopathy, some with both. I would say in this case, someone with two variants, once there's any development of disease, the targeted treatments that Dr. Lyle nicely outlined in her talk earlier is going to be very similar. I mean, when there's polyneuropathy, you would use a silencer, probably in combination with a stabilizer in this case, because with those two variants, there's a high likelihood of development of cardiomyopathy. So I would consider putting someone both a silencer as well as a stabilizer, even though, and this was touched on earlier, we don't have much data on combination therapy. But I mean, I think this is one of the instances where it may make sense.
Dr. Karam?
Yeah, I agree. I mean, I think we still treat the disease the same way we treat people with one variant. I mean, obviously, it's unfortunate bad luck of having two variants, but again, the treatment will be the same, and hopefully it'll be as efficacious as if the person had just one variant.
And Dr. Lyle?
Yes, I agree with what already has been said, but I do think that in this instance, a combination of a stabilizer and a silencer would be very reasonable.
Okay, great. Well, we're going to stop with the Q&A for now. Okay, we'll continue with more after we hear from our pharma folk. And I'm going to send you all copies of all the questions. Okay, so any that don't get answered today, if you kind of type in an answer so that I can send them to, because I always promise everyone they'll get all their questions answered, and I don't want to be a liar, so therefore you have to help make me honest, keep me honest. Okay. And now, thank you so much. Okay, let's have everyone, our doctors and our pharma up there, and this has really been great. Thank you so much. Attralus, Spencer. Okay, now you mentioned I remember when everybody was going to the University of Tennessee to get imaged. That was kind of an exciting thing for all of our patients, and they all want to get imaged still. Now that's the AT01, right? Okay, if patients want to get imaged, is there still an opportunity, and they don't meet the criteria necessarily to go to Columbia, or no, I think you said there were some openings in Boston for ATTR, and Dr. Masri had some openings also in Oregon. But if they don't meet the criteria for that and they want to get imaged, is there any openings to go to the University of Tennessee and get imaged?
Yeah, so as I mentioned, not for AT01, but this next product, AT05, which uses a SPECT platform, we anticipate that to be open this quarter, and that will be there will be a number of spots for TTR patients, both hereditary and wild type.
Okay.
So keep your eyes peeled, and I'll just send you a message, Muriel, as soon as it's open.
That's great. You heard today mention that people seem to they don't just have cardiac with wild type, they also have neuropathy, and they don't just have neuropathy if they have a neuropathy variant for hereditary, they also have cardiac. I'm sure in your imaging you found that to be true for sure, that people had it in other, and you mentioned it in other places besides the heart and the nerves. What does, I'll use the expression light up for lack of a better term, do the nerves light up when you do your imaging?
Yeah, so I mean, I can categorically say it doesn't work as well for the nerves. So we have seen nerves light up, but not in the majority of patients who have neuropathy. So it is not, having said that, these are whole body scans. So you spend only a few minutes focused on specific parts of the body, and there hasn't been a nerve focused study where someone does really deep nerve imaging. So it could get better. There are, other imaging modalities like PET MR combinations, which probably would be better. But as of now, it's not entirely surprising. It's very hard to image nerves, and the amount of amyloid in nerves around nerves is much less than you would see in other organs.
So, Dr. Karam, would that mean that it takes less amyloid in the nerves to cause problems then? If there's less, you don't need that much in the nerves to cause problems?
Yeah, Muriel, that's a great question, and I tried to allude to this issue earlier in my talk. Do we really need amyloid to be deposited in the nerve to have neuropathy, or is the circulating misfolded TTR toxic to the nerve? So that's something that obviously has a lot of implication, and it's a little bit different from the cardiac disease, and that's probably has also implication on the wild type, cardiac versus neuropathy. Why don't a lot of cardiac have neuropathy? So it's a complicated question. I think we need a little bit more research, but one explanation is maybe just the circulating amyloid or TTR is toxic to the nerve rather than big deposition of the nerve causing, nerve dysfunction.
Great. And I have a quickie question for Dr. Cheng and Dr. Lyle. And this reverts back to the treating with diflunisal if you're not yet symptomatic, but you inherited the gene. Okay, this won't go away, just so you know. Okay. Would checking the pre-albumin levels of a patient influence you at all, even if they're not symptomatic, and whether or not to treat them with diflunisal if they're not symptomatic?
Yeah, I think that's a great question. I do, as I mentioned, check pre-albumin TTR levels on all of my patients. If it was significantly lower than the normal, then I think it's, again, an ongoing discussion with the patient, but that might tip the scales, particularly if we're seeing other biomarkers that are mildly elevated or subclinical disease on their nuclear PYP. So potentially, but I think it's an important biomarker that I do assess as I'm getting the initial evaluation.
Dr. Cheng?
Yeah, so we systematically check TTR on all our patients. Keep in mind that it's actually not a specific biomarker. A lot of different things can and will impact the transthyretin levels. For example, nutritional status. For someone with suboptimal nutrition, the serum TTR will be lower because it's you're just gonna make less of it. So I think there's a lot of factors that may impact it. I think in general, I personally don't use it to guide when to start something like diflunisal, with the rationale that if your circulating TTR is reduced, not on therapy, it should probably be sufficient to result in a clinical manifestation, because usually by the time those levels are low, you're going to have to pause it somewhere. I did also want to say there's a lot of interest, and I know some individuals possibly on this session are looking at the role of retinal binding protein also. So circulating RBP, there's a lot of data showing that may also correlate with systemic TTR.
Thank you. This has been absolutely, I think, the best. Okay, but don't let the other doctors and hear this. Okay, but absolutely. But and make sure everyone, while I'm talking right now, go to the chat and see if there's anything that you want to write down. And I hope to see all of you in October in Chicago. The hotel block is filling up, so make sure you book your hotel rooms if you haven't. Okay, even if you have to cancel, you don't have to pay for it until 48 hours before or something like that. So definitely book your hotel rooms. Okay, and I want to thank our panelists, our presenters, our attendees. Bob will make sure that the recording is up on our YouTube channel and ASG website in a couple of weeks, maybe less. He's working on it, right, Bob? They'll also be shared on When Amyloidosis Voice, our Facebook groups. We'll send out emails when they're ready. Till then, please stay safe, okay? Let us know if there's anything we can help. Send emails, questions. We're going to have our doctors answer the questions that you've already sent in. No new ones. We're calling a halt right now, okay? And remember, we're always available day or night. We prefer day, but we're always available. Okay. Thank you to everyone. Take care.
Thank you.
Thank you.
Bye-bye.
Thank you.